My topic for today is topical anesthesia. The technique which I will be showing here is not exactly a topical SICS. It can be called a no injection SICS. From the patient perspective, no injection is being given to the eye. All of us are scared of injections, and when you ask the patient, they are more scared of injection rather than the surgery itself. And we all know there are a lot of complications of peribulbar blocks, which ranges from sight-threatening to life-threatening problems. And the painful structures in the eye are conjunctiva, sclera, cornea and iris. And touching and stretching of all these tissues can cause pain. All these structures can be anesthetized without giving a block, provided the surgery has to be finished at least within 10 to 15 minutes. And one should not get upset by operating on a moving eye. And to start your topical SICS, you have to have a good patient selection. An ideal case would be a prominent eye with a well-dilated pupil and a grade 2 to 3 nucleus. And it is always better to avoid over-anxious patients and patients with hearing problems as well as language problems, as we need to communicate with the patient before the surgery as well as in between the surgery. And avoid complicated cases like small pupil, subluxated cataracts, black nucleus, etc. Also deep sockets where we may expect more surgical time. And you have to explain the patient very well before the surgery itself. Also, you have to reassure the patient in between the surgery every now and then. And proparacaine 0.5% is instilled 3 times in a 5 minutes interval to anesthetize the conjunctiva. And injection lignocaine 2% is used to infiltrate subconjunctivally to anesthetize the sclera. And a preservative-free lignocaine is used intracamerally to anesthetize the iris. And one should be confident in SICS with a block. And in case of any complications like a posterior capsular wrench, the anesthesia should be augmented with subtenons, or it is better to stop the surgery and give a block and after some time restart the surgery. A small nick, after anesthetizing with proparacaine, a small nick is made in the conjunctiva and 2% xylocaine is infiltrated subconjunctivally, and this is a temporal tunnel, and I have not taken a rectus suture, as taking a rectus suture would be painful. And after doing peritomy, you have to ask the patient to look towards the opposite direction. That is, in case of temporal tunnel, you have to ask the patient to look towards the nasal side, and that tunnel is being made. And while making the tunnel, the hold of the conjunctiva with tenons at its insertion is very important, as there is no rectus suture and the eye will be moving. So the hold of conjunctiva is very important. And iris is anesthetized by lavaging the anterior chamber with 1% preservative-free lignocaine for 20 to 30 seconds. And usually the tunnel bleeds a lot because we have not given any block. The rectus is done. And while extending the tunnel also, the hold on the conjunctiva is very important, and the hold should be very gentle, not to press much on the glove. After doing hydrodissection and delineation, the nucleus is prolapsed into the anterior chamber using a 2-instrument technique. And I am using an irrigating vectis to deliver the nucleus. And delivering the nucleus, after engaging the nucleus in the vectis, you have to ask the patient to look towards the nasal direction, and the voluntary movement of the patient in the opposite direction will help in delivering the nucleus. The rest of the epinucleus is visco-expressed. The cortex is washed. Before inserting the intraocular lens, you can augment the anesthesia. Like once again, you irrigate the tunnel with lignocaine, preservative-free lignocaine, and a PMMA lens is inserted into the bag. And after removing the visco, surgery is completed. Watertight tunnel and side port is attained, and the cautery is applied. Just to demonstrate the movements. And you have to ask the patient to look down and take out the speculum. 2 steps needs extra care where patient can experience some amount of pain, that is tunnel construction and nucleus delivery. Highlighting those 2 steps once again. And the hold on the conjunctiva with tenons at its insertion is very important. You have to hold it very gently, not to press much onto the globe. And always use a new blade. Usually for SICS, we tend to use autoclaved blades for 2 to 3 cases. So it is always better to use a new blade so that your tunneling will be easy. And the nucleus delivery, you have to have an adequate size tunnel, and the voluntary adduction movement of the patient is used in delivering the nucleus. You can see the jerky movement. The patient was looking towards the nasal side. Surgery is complete. You can experience some difficulties, like some patients, especially over-anxious patients, will not allow, they will keep on squeezing their lids. Like this patient is not allowing me to touch on the conjunctiva, and they'll roll their eyes up, so that tunnel construction will be very difficult. One more video. My senior colleague Dr. Shashikumar does exclusive SICS practice. This is his video. He makes a small external tunnel in the beginning. Actually, his patients walks directly into the OT without even dilating the pupil, without a block, and he dilates the pupil intraoperatively using intracameral diluted adrenaline. You can see the pupil is well dilated now. The tunnel is being extended. And delivering the nucleus with a sandwich technique after bisecting the nucleus into pieces. Surgery is complete. And converting into no injection SICS will help you practice tremendously. The patients will spread the word that no injection is being given, and the patients will come back for the other eye immediately at the earliest, and you will have a better practice. Thank you.